Hello everyone, this is Dr. Frances Munroe, and today I'm going to talk with you a little bit about the management of thyroid nodules, thyroid cancer, and subclinical thyroid diseases. So what exactly is a thyroid nodule and why is it so important? As you can see by the picture, the thyroid nodule can be either a discrete lesion, show up as an enlarged goiter within the thyroid gland. It is radiologically distinct from the rest of the thyroid tissue. Some of the palpable lesions may not correspond to radiologic abnormalities, but we do have to be aware of the increasing incidence of thyroid cancer. We're also going to discuss the use of ultrasonography imaging and fine needle aspiration, how to manage nodules within a multinodular goiter, the management of functioning nodules, and when to refer to endocrinology. As you can see by the graph provided by the National Cancer Institute, the number of new cases of thyroid cancer has slowly increased. This time period is from 1975 to 2011, looking at all ages, all races, and both sexes. These are rates, number of cases per 100,000 persons. If we look just specifically by age group at the cancer incidence from 1975 to 2011, including all races and both sexes, you can see a dramatic increase in the age group of middle age. Starting with around age 35, we see a sharp increase and starting to taper off in the mid-70s and 80s. This is a very interesting graph from an older article by Mazzaferri that shows the prevalence of palpable thyroid nodules that were detected at autopsy or by ultrasound versus by palpation, just showing how difficult it is to palpate some of these small thyroid nodules. And these were all in subjects without radiation exposure or known thyroid disease. What this basically shows is that by the age of 30, almost 20% of the population has a thyroid nodule, usually women more than men, and the likelihood of malignancy in these nodules is higher in the extremes of age, either the very young, less than 20 years old, or the elderly, greater than 70. The lifetime likelihood of someone with a thyroid nodule having cancer is approximately 60%. So with the discovery of a thyroid nodule, your first step is to do a complete history and physical exam focusing on the thyroid gland and the adjacent cervical lymph nodes in case there's any enlargement. Some very important history factors that may predict malignancy would include a history of any childhood head and neck radiation, any total body radiation for bone marrow transplants, any family history of thyroid cancer or thyroid cancer syndromes, anything in a first-degree relative, previous exposure to ionizing radiation from any fallout in childhood or adolescence. Any pertinent physical findings that could lead to possible malignancy would include vocal cord paralysis, lateral cervical lymphadenopathy, and fixation of the nodule to any surrounding types of tissues. So thyroid ultrasound should be performed in all patients with a known or suspected thyroid nodules, especially those that you can palpate. The serum TSH should be measured during your initial evaluation, and if it is subnormal, a radionuclide thyroid scan should be performed. If the serum TSH is normal or elevated, the radionuclide scan should not be performed as the initial imaging evaluation. And routine measurement of serum thyroglobulin is not recommended. These are based upon the ATA guidelines for the management of thyroid nodules, which are brand new and still in press. These are strong recommendations with moderate quality of evidence. As I mentioned earlier, a diagnostic thyroid ultrasound should be performed in all patients with a suspected thyroid nodule, nodular goiter, or radiographic abnormality. For example, a nodule that's found incidentally during CT scan, MRI, or PET scan. The thyroid ultrasound can answer the following questions. Is there really a nodule that corresponds to the palpable abnormality? How large is the nodule? Does it have benign or suspicious features? Is there any cervical lymphadenopathy present? Is the nodule greater than 50% cystic? And where is it located? Which would be very important for fine needle aspiration. There may be other thyroid nodules present that require biopsy based on their size. And the FNA is especially recommended when the serum TSH is elevated because compared with normal thyroid glands, the rate of malignancy in nodules and thyroid glands involved with Hashimoto's thyroiditis is a little bit higher. So if we take a look at the ultrasound patterns and features, high suspicion would be a solid hypoechoic nodule or solid hypoechoic component of a partially cystic nodule with suspicious features, the greatest risk of malignancy, and consider biopsy if these are greater than 1 centimeter in size. An intermediate suspicion pattern would show the ultrasound features of the hypoechoic solid nodule with smooth margins without those suspicious features. Only a 10 to 20% malignancy risk. The low suspicion would be the nodules with eccentric solid areas without the suspicious features, and the very low suspicion ones would be partially cystic nodules without the features. Benign or purely cystic nodules, no solid component, less than a 1% malignancy risk, and no biopsy is recommended for those. So for hyperfunctioning thyroid nodules, you would suspect an autonomous nodule if the serum TSH is low or low normal in patients who have multiple nodules. The technetium-99 thyroid scan should be considered and directly compared to the ultrasound images to really look at the functionality of each of the nodules that are greater than 1 centimeter in size. The fine needle aspiration biopsy should only be considered for the isofunctioning or non-functioning nodules. Again, suspicious features would include irregular margins, microcalcifications, a taller rather than wide shape, rim calcifications, and evidence of any extrathyroidal extension. Benign thyroid nodules, basically the diagnosis is made based upon that ultrasound pattern as we mentioned earlier. Nodules with a high suspicion, repeat your ultrasound and ultrasound fine needle aspiration. If there is a low to intermediate suspicion, you can repeat the ultrasound in 1 or 2 years, and if there's evidence of more growth, continue to repeat it. Nodules with a very low suspicion do not need to have an ultrasound repeated, but if you do, it should be, greater than 2 years before you repeat that again. This is a nice wrap-up of thyroid nodules, looking at the algorithm, again paying attention to the size of the nodule. On the ultrasound, we're really looking at nodules that are greater than 1 centimeter, looking at the low thyrotropin level, then ordering the thyroid scan, determining whether it's a cold nodule or a hot nodule. Hot nodules needing to be surgically resected and treated, either that or through ablation. If the ultrasound guided fine needle aspiration is done and there is a satisfactory result, then again you're looking at one end of the continuum from benign and just continuous monitoring all the way up to malignant and having the thyroid gland removed. If there is any level of indetermination, then repeating your fine needle aspiration until you get a satisfactory result is important. Again, for benign findings, you're going to continue to monitor. For suspicious findings, you're going to recommend referral to the surgeon. Again, to summarize, the fine needle aspiration is the most accurate and cost-effective method for evaluating thyroid nodules. Retrospective studies have reported lower rates of false negative specimens from the FNA procedures. And so therefore, for nodules with a higher likelihood of either a non-diagnostic cytology or sampling error, the ultrasound-guided fine needle aspiration is preferred. Routine fine needle aspiration is not recommended for the sub-centimeter nodules, but the presence of a solid hypoechoic nodule with microcalcifications is highly suggestive of carcinoma. And they may be incidental findings, but a subset of these can be clinically relevant, especially those that are greater than 5 millimeters in diameter. These include nodules that have abnormal lymph nodes detected. Therefore, after imaging a subcentimeter nodule that looks suspicious, if there's any lymph node involvement, the fine needle aspiration should be done. Also, detection of the abnormal lymph nodes along with family history of cancer, history of any radiation exposure would also be an indicator for the fine needle aspiration. Next, let's take a look at the topics of subclinical thyroid disease. We're going to start with subclinical hyperthyroidism. Subclinical hyperthyroidism is indeed a form of hyperthyroidism, indicating that as the TSH progressively decreases, this can lead to worsening thyroid overactivity and the probability that a clinically significant consequence will occur. So subclinical hyperthyroidism is usually divided into two categories: exogenous disease, which is caused intentionally or unintentionally by thyroid hormone therapy, and endogenous disease that is caused by several different conditions that can be responsible for most forms of overt hyperthyroidism. The exogenous subclinical hyperthyroidism is much more common than the endogenous form because of the widespread use of thyroid hormone replacement, which is used both to treat hypothyroidism and to provide suppressive therapy in patients with non-toxic multinodular goiters and thyroid cancer. Up to 40% of patients who take thyroid hormone have a low serum TSH concentration. The exogenous subclinical hyperthyroidism is often reversible by reduction of the levothyroxine dose. So we're going to look more at the endogenous form. Both of them can cause deleterious effects that are seen with endogenous disease. Some of those endogenous diseases include the toxic multinodular goiter and Graves' disease. I've also listed some causes of transient subclinical hyperthyroidism and the evolution of various forms of thyroiditis, including subacute thyroiditis, silent thyroiditis, which typically develops in the postpartum period, and the occasional thyrotoxicosis induced by amiodarone. There are also some causes of low serum TSH that are not related to subclinical hyperthyroidism. Often we see a low serum TSH at the end of the first trimester of pregnancy. This can also occur in severe non-thyroidal illness with treatment with high-dose glucocorticoids or dopamine. Some elderly individuals without any apparent thyroid disease can have an elevated TSH. Often you can see this in smokers, sometimes in African American individuals as a consequence of racial differences, and serum TSH levels below the reference range, but at a normal concentration for that individual, because the reference range only encompasses about 95 to 97.5% of the general population. Let's take a look at some of the management options for you to consider when you're evaluating your patient who comes in with persistently low serum TSH levels, yet they have the normal free T4 and the free T3 concentrations. So the first thing you may want to do is assess with the radioisotope imaging. Consider doing the Doppler thyroid ultrasound with color flow. If we take a look on the left side of the chart, you can see that the assessment showing subclinical hyperthyroidism due to a toxic multinodular goiter or solitary adenoma looks different than the right column, which shows the subclinical hyperthyroidism due to Graves' disease. Take a look at the serum TSH levels below 0.1 versus greater than 0.1 in order to look at the differences in treatment options for patients with TSH below 0.1. Treatment with radioactive iodine is indicated, especially in patients older than 65 years of age, because of the risk of atrial fibrillation and osteoporosis, which are much more dangerous in this age group. If the serum TSH is greater than 0.1, you can again consider treatment with radioactive iodine, especially in the older population. Again, we want to prevent and lower that risk of atrial fibrillation and osteoporosis. If the assessment shows subclinical hyperthyroidism due to Graves' disease and the serum TSH is less than 0.1, again, treatment with radioactive iodine is indicated, especially for the elderly. If the TSH levels are higher, you can wait and observe. There is sometimes a remission rate. You can think about low-dose antithyroid medication with tapazole. This could be considered, especially in patients older than 65 or patients with a high risk for heart disease. Next, we're going to take a look at subclinical hypothyroidism, which can cause some controversy. However, most experts would agree that the subclinical hypothyroidism does represent an early, mild start to thyroid failure. What it depends on is the size of the increase in the serum TSH, whether or not you classify subclinical hypothyroidism as mild with serum TSH levels of 4.5 to 9, or severe where the TSH is greater than or equal to 10 milliliter units per liter. At least 75% of patients with subclinical hypothyroidism have very mild thyroid dysfunction with the TSH less than or equal to 10. And there are a lot of controversies over what that correct upper limit range should be. Subclinical hypothyroidism has various causes, as you can see by the list. In about 60 to 80% of cases, subclinical hypothyroidism is associated with antithyroid peroxidase antibodies, which are a marker of chronic Hashimoto's thyroiditis. Hashimoto's is more common in girls and women, and the overall incidence increases with age in both sexes. Patients treated with overt thyroid failure often have subclinical hypothyroidism because of inadequate supplementation, poor adherence to the medications, drug interactions, or lack of monitoring of their treatment. Subclinical hypothyroidism is much more common in iodine-sufficient countries, and iodine supplementation might actually increase the incidence. Subclinical hypothyroidism occurs in about 4 to 20% of the adult population worldwide, and this wide range is a result of differences in age, sex, BMI, race, dietary iodine intake, and the cutoff for TSH that's used to define the condition. In the U.S. population, the prevalence of subclinical hypothyroidism is about 4.3%. And the prevalence of a raised serum TSH is higher in white people rather than African American population, and this supports a genetic effect on TSH secretion. Some other causes of increased serum TSH concentrations that are not related to subclinical hypothyroidism can be a lab error, lab problem. Sometimes very obese patients may have transient elevations in TSH. Elderly patients can have small increases. There can be a TSH secreting pituitary adenoma, or resistance to thyroid hormone, impaired renal function, untreated adrenal insufficiency, and again, errors with the reference range as we mentioned earlier. Predisposition to autoimmune thyroiditis may be increased by familial and genetic risk factors such as a family history of autoimmune thyroid disease, other endocrine or autoimmune disorders, or genetic disorders. A high antithyroid autoantibody titer is associated with persistently raised serum TSH concentrations. Subclinical hypothyroidism should be distinguished from other causes of elevated TSH levels, and repeat serum TSH concentration should be rechecked again after 3 to 6 months to rule out any lab error or just a transient increase that could be caused by other reasons, for example, medication interference, thyroiditis, or type of injury to the thyroid gland. Subclinical hypothyroidism is usually progressive. It can be reversible in some cases, especially when the serum TSH levels are less than 10. The serum TSH greater than 10, female sex, and the presence of the antithyroid peroxidase antibodies are usually associated with the increased risk of progression to fully overt hypothyroidism. And approximately 4% of women with raised serum TSH and the positive antibodies will go on to have full-blown hypothyroidism. So let's take a look at the treatment algorithm for subclinical hypothyroidism. If we look at a persistently elevated serum TSH, you can see that it's broken down into 2 levels, serum TSH of a 5 to 9, and then serum TSH persistently elevated greater than or equal to 10. If we look on the left side and we've got that serum TSH persistently between 5 and 9, you could consider starting treatment in young and middle-aged patients, especially if they're symptomatic, have a goiter, positive antithyroid antibody titers, dyslipidemia, other heart disease risks, or they're pregnant. Treating with levothyroxine, your goal should be a serum TSH of about 0.5 to 2.5 in young patients, slightly higher values of 4 to 6 in the elderly. If we move to the middle column, you can see there is no treatment necessary for a TSH of 5 to 9 in patients 85 years or older. In patients 65 years or older, though, you can treat to a TSH of about 7. In asymptomatic patients who are younger than 65, if they don't have symptoms of goiter, the positive antibodies, dyslipidemia, and they're not pregnant, you can either treat or observe. Either one is reasonable, but treatment should be considered if there is progressive increase in the serum TSH over time. Some patients may have a spontaneous recovery and go back to normal thyroid function. When we get to our last column on the right, if we look at the serum TSH of greater than or equal to 10, we would want to start treatment with levothyroxine with a goal serum TSH of about 0.5 to 2.5 in the young and middle-aged patient, higher values of 4 to 6 in the elderly patients. Again, we want to prevent any atrial fibrillation or osteoporosis. Thank you for listening to today's presentation. I've also included several references that were mentioned throughout the presentation and can be found in your reading list also.